Of teaching experience. Index and citation index. We are fortunate to have such an eminent personality amongst us to be the examination.
Dear President, dear presenters, we hope that you are ready. So we got about 27 participants. So, and we have to finish before 4 o'clock because we're going to start the valediction. So maximum you can take about 2 to 3 minutes. Don't read the full paper. Tell the importance of your paper, why you're presented that paper, what are the major objectives, and what did you understand by publishing this paper. Okay. And without wasting much time, I would like to request you to start your presentation one by one. You introduce your name and then your topic, and then you can start.
The first presenter for the day is Sharon PR and S. Sita Lakshmi. I request you to start your presentation.
The next presenter is Sudha and Moon Hussain.
Yeah, ma'am. I share my screen. PPT.
You can start your
Yeah, ma'am. Can you my PPT, ma'am? Ma'am?
Yes, you can see the PPT, please. You can start, ma'am.
Okay. I'm Sudha. I'm doing PhD in BS Abdul Rahman Crescent Institute of Science and Technology under the guidance of Dr. Moon Hussain in the Department of School of Social Science and Humanities. This is our topic. This is my topic, mental health issues of the migrants among COVID-19 pandemic in India. So this topic mainly concentrate on the mental health issues of the migrant laborers. Okay. So I just introduced small things only about COVID-19. So in 2019 December, World Health Organization introduced the COVID-19 epidemic period. Initially, they called the health emergency. Then in January month, they used the word COVID-19 is a epidemic. Then again, they changed the new word to the COVID-19 COVID-19 word is like that pandemic. So at the time of this March 24th, in India, they implemented the lockdown. So this time, migrant workers are hugely affected. So in India, nearly 100 million migrant workers are there from various states like us, West Bengal, Jharkhand, Uttar Pradesh, Orissa, Bihar, Tamil Nadu, etc. So many states having the migrant workers. They migrated due to the lack of jobs in their native place or various reasons. They migrated to other areas. So this paper mainly concentrate on the reviews. So review article collected from various journal websites such as PubMed, Google Scholar, Web of Science, Science Direct newspaper, and Google. So here this paper mainly concentrate on the review of literature. So just I saw 3-4 reviews. So one of the study found that 20% of the participants felt down or gloomy, and 19% of the migrants felt restless. It's one of the study. That another study from the North India published as a letter to the editor found 73% of migrants to be depressed. So another one of the study, it is a primary study data. They study among 353 migrants found that 31% suffered from mental stress and anxiety. So in India, this period is hugely painful to the migrant workers. So this why the health issues happen because of so many reasons. So it's one of the study shows that lack of employment, starvation, unsanitary conditions, lack of housing and transportation facility, insecurity, unemployment, lack of social protections, uncertainty in life, and other crises they faced during this time. So now this period 2019 to 2021, this period many papers concentrate on the health issues related to migrants. So our analysis, we found some of the factors for facing the mental health issues problem of migrants. For example, some of the factors I'm showing: fear of losing their job, shelters and regular food and water, the psychological distress, depressive disorders, anxiety disorders, tobacco and alcohol, health issues, loss of social status, death. So these are the main reasons to create the mental health problems to the migrant workers during the COVID-19 pandemic. So these are the things we found. So then we found these the reasons why these reasons came during that time means because many people lose their job. So that is the main reason. That's why it creates the anxiety about the future. So if they lose their job in future means definitely their income is question mark. So that's why they have many stress in about future. So it creates many health issues. So health issues are different from psychological issues. Mental health issues includes the psychological issues. So we conclude with some 2-3 points. Basic needs and medical needs and social needs. These are the 3 things are highly associated with the mental health issues of the migrants. So I give 2 suggestions. Health insurance programs must be implemented, and national communicable and non-communicable disease health programs need to be reviewed and strengthened. And one more thing I need to mention here. So health insurance programs I mentioned. So simultaneously, I appreciate our Tamil Nadu government used the, before they introduced the medical card facility to the poor people. They used this facility during the COVID time effectively. Many poor people got benefited during the COVID-19. Because this is the very big positive point from the Tamil Nadu government. It is a big example. So that's the facility provided to the local people. But the migrant people, they will not get this facility. So in future, not only Tamil Nadu, in other states also, they provide health insurance, health facilities, insurance programs to the local, not only to the local people, but also due to migrant people. That will they will get some benefit from government through health insurance. So that's why this is one of the suggestion. So this is our my paper. So any questions, please ask me. Ma'am, do you have any questions? Just ask me.
Ma'am, organizers, are you there, ma'am? Organizers? I think organizers are not there in the meet.
Oh, okay.
Organizers, are you there? Just take the phone call, Sita Lakshmi.
Can you hear us?
Ma'am, I'm not able to hear the voice. Any ma'am, any questions you ask me, ma'am?
Madam, could you tell me the latest health insurance program which is popular among the people?
Yes, sir.
Health insurance program, latest health insurance program which is
Yeah.
popular among the people. Could you mention?
No, sir.
Because a lot of programs are there. Health insurance.
Yes, sir.
You have mentioned a lot of health insurance programs for. That's why I asked you.
Okay, sir. Actually, it's a general insurance available, but
Yes.
I concentrate only on the migrant workers.
Fine.
So
I
that's
joined
why-
only. I only joined only later part of our lecture. That's
Oh,
why.
okay, sir.
I
So
want
I
to cover the
mainly
entire.
concentrate on the migrant workers.
Okay.
That's why.
Okay.
Okay, sir. Thank
I'm Dr. Kalimurthy. Shall I present, please?
Yeah, sir. One more thing, sir. Thank you so much, sir, for giving this opportunity to me. And also, I thank to my guide, Dr. Munmul Hussain, and also the convener of this program, Sita Lakshmi, ma'am. Thank you so much.
Yeah, thank you, ma'am. Thank you so much.
Thank you.
It was a good presentation.
Thank you, sir.
Thank you.
Thank you.
Shall I present, sir? Dr. Kaliyamurthy on health, women and health.
The next participant is M. Malarvili. M. Malarvili, if you're ready, you can present now. Malarvili.
Emma.
Participants, you're requested to wait for 5 minutes.
Ma'am, already we are waiting for half an hour. Again, 5 minutes you're telling us to wait.
Yes, ma'am.
Check,
Now we are
test.
going to start. Just 1 minute, 1 second.
If you're ready, you can present now. Bhagya Lakshmi, M.
Fourth number. Next to Bhagyalakshmi.
Check.
Madhurima, if you're ready, you can present. Madhurima.
Yes, ma'am. Good afternoon, everyone. I am Madhurima from St. Anne's College, first year BA student. My topic is about health and well-being and its economic impact. So, health and well-being are interconnected and interrelated topics, and they are mutually dependent on each other. And well-being is a state of being healthy, satisfied, and happy, and it basically translates to one's choices for oneself. It has greater significance and impact on all the aspect of one's health. So the health of citizens of a nation plays a crucial role in the level of output production, and which in turn affects the GDP of a country. The human resources are very precious and contribute substantially in the economic sphere, and therefore the health aspect and well-being aspect of the citizens must be given a priority, especially in times of such pandemic like COVID-19. And there is a saying in Indian culture in Sanskrit that Sharira Madhyam Khalu Dharma Sadhanam, which roughly is translated to body is the vehicle or means to fulfill all activities or responsibilities and virtuous deed by an individual. So this is something which is given a priority since the ancient times, and it should be given more importance in the coming days. And coming to well-being, it is to be made, there should be a conscious choice of an individual. Yes, ma'am.
Share your PPT.
Ma'am, I actually have a technical issue, so I'm unable to share it.
Okay, you can continue, Madhurima.
Okay, ma'am. And some lifestyle-related diseases or issues can be substantially decreased by giving priority to the health sector in India. And as a result, it will promote a productive, healthy, and vibrant society, leading to a better quality of life for people. The sooner the society and governments realize and invest in it, the better outcome will be for the future generations as well. So I would like to conclude by saying human resources are precious, and deriving optimum output and increasing the quality of life will help in progress of a nation. Thank you.
Thank you, Madhurima.
Hello, check. Madhurima, are you there?
Yes, sir.
Yeah, is yours a working paper? Have you done some kind of research? Do you collect some data, or it is just your opinion which you
So this is
presented?
my opinion on it. I have researched about basic concepts of health and wellness from sources like WHO and Health Ministry, and this is the opinion I have come to.
Okay, thank you very much.
Thank you, sir.
All the participants be ready with your PPT. Now, M. Kiran Kumar and A. Sendal Raja. You can proceed with your PPT. Kiran Kumar and A. Sendal Raja.
Good morning, good afternoon, everyone. I am Department of Environmental Economics, School of Economics, Madurai Government University. I present the entitled an economic analysis of public expenditure on healthcare in Tamil Nadu. Introduction. Health is a state of physical, mental, and social well-being. Health maintained and improving not only through the advancement and the application of health science, but also through the effort of intelligent lifestyle choices of individual and society. According to the World Health Organization, the main determinants of health include the social and economic environment, the physical environment, and the person's individual characters and behaviors. A healthy mind and proper intelligence development will help proper manpower that is suitable for economic growth. And with greater economic growth, better health facilities are required, and also possible environmental implications of development as well as the opportunities created for attending health through the better facilities. In launched the National Family Welfare Program in 1951 with the objective of regarding reducing the birth rate to the existing necessary to establish the population at a level considered with the requirement of the national economy. The family welfare program in India was recognized as a priority area and being the implemented as a 100% of centrally sponsored program. According to the 10th 5-year plan 2002-2007 of Tamil Nadu, health for all was the main objective of the program. It focused on improvement in the general health status of the population, better access to health care services, improved mental and child health care, effective control and prevention of communicable and non-communicable diseases. And the common objective World Health Organization definition is effect and upon any and all attempts to specify the meaning of very general concepts who can possible define words and are as a very on the health. A venture virus in the trying the different justice in the happiness and other systematically combination to the objection of the programming candidates and are the anyway it's put necessary unnecessary to the water the health means in order to treat the patient and the running high temperature. Not only that but it also harmful distraction to the health medical judgment with philosophical pursuits. Unfortunately, for this line, the arguments it's impossible to the thanks in the all without employing general concepts without them consent and language and this statement of the problem. Health has been identified and accepted as an important factor in human development. The Constitution of the World Health Organization defined health as a state of complete physical and mental and social well-being, and not mentally the absence of disease or infirmity. This the health of the community has to be viewed from the bird and the perspective than merely in the terms of demographic indicators. The basic objective of any healthcare delivery system, therefore, the would be provide and organize the service in such a way that reach everyone and available resources, the knowledge and the technology of are optimally utilized. In India, several policy initiatives have been taken into consideration from time to time in this direction to analyze on various aspects of the delivery and the healthcare, family welfare, and accessibility. But the present and the study focus on family healthcare. The methodology, the data is collected from the secondary data sources, Reserve Bank of India, the simple linear regression model, and the annual growth rate are computed in the study. The aim of the study is to evaluate the health status of the people of Tamil Nadu, to identify the trends and total health expenditure in Tamil Nadu, to examine the trends in public health and family welfare. The table 1, the revealed that the total expenditure on health in Tamil Nadu from 2006 to 2020, the lowest value of the 1/4 the in 9 million is recorded in the year 2016, and the value of 398.20 million is registered in 2020, and who serves continues increasing after the year 2006. The annual growth rate of total expenditure on health indicates the follow-up government spending on health between the year 2009 and 2011 was 0.3% and 0.16% respectively. The government of Tamil Nadu has been declining the above the said period. The table 2, the above table 2 shows the trend in public health and family welfare in Tamil Nadu during the period 2006 to 2020. The lowest value of public health expenditure and family welfare are as 2,398 million and 1,105 is recorded in the year 2016, and the highest value of rupees 189.606 million and 39.343 million is registered in 2018, and its source and continues the reduce after the year 2008 public health expenditure and family welfare. The tables conclude that the government of Tamil Nadu did not give the more importance of family welfare because of the whole amount transferred in the census of expenses. Conclusion: the family welfare program is implemented as a people program involving in the active cooperation of community at a large, improving the mental and child health services, and hereby the stability and the population growth. Tamil Nadu is the model state in the introduction of community needs assessment approach to all the states in the country. The success of family welfare program in the state has been attributed to several factors, include among the social, political, community, and the administrative backup. Thank you, ma'am.
Yeah. Kiran Kumar, thank you so much for that presentation. I want to ask only one question. You were talking about the expenditure of the Tamil Nadu government in terms
Yes,
of
sir.
family welfare.
Yes, sir.
And you said it is quite low, only 2,300 and something is being spent. And you say that is the model for the country. So you mean to say that rest of the country are spending much lower than Tamil Nadu?
Yes, sir.
Okay. Thank you very much.
Okay, thank you, sir.
Thank you, Kiran Kumar. The next participant is G. Anandi and K. Kaliyamurthy. G. Anandi, if you're ready with your presentation, you can present it now. G. Anandi and K. Kaliyamurthy, this is your last call. Prasannajeet S. Bade, Neha K. Satolia, if you are ready with your presentations, you can start sharing your screen.
Yes, good afternoon, ma'am. We are ready with our presentation. We will just start sharing the screen. Good afternoon, everyone. Can you all see the screen?
Yes, we can see your screen.
Great. Good afternoon, everyone. This is a joint paper, the relationship between infant mortality rate, economic growth, and health expenditure in India. It's a joint paper by Mr. Prasannajeet S. Bhave and me, Professor Neha Satolia. This is the introduction that in India, infant mortality rate is a big concern, not only in India, but also or in all the developing countries in the nation, in the world. So infant mortality rate means the number of deaths of infants under the 1 year of age per 1,000 lives birth in a given population. Excessive quantum of health expenditure is necessary for reducing IMR, and we all know that better health can increase the productivity, and that can lead economy and country towards development. So that is why it becomes very important that IMR over the period of time should be reduced and measures should be taken. So the present paper, considering the same, analyzes the relationship between three very important variables, that is infant mortality rate, economic growth, and also the health expenditure. So these are the review of literature we have done. So one is the first one. I have actually done more than reviewed 7 to 8 papers, but due to the lack of time, I have just mentioned 4 here. Mohapatra was the first to examine the 3 parts of it. According to him, in his paper, he was the first to examine 3-part relationship between economic development, public health expenditure, and health outcomes at the state level. For A, states that health expenditure, health status, and economic growth in India have a long-term relationship, and there is a presence of unidirectional cause link between government health expenditure and GDP, life expectancy, and IMR, that is infant mortality rate. There is Shetty A and Shetty S. In 2014, demonstrates per capita state health spending was the most important factor of IMR, and nations with a higher per health spending had much lower levels of IMR. So, and next is Berenberg, AJ Basu, and D. Soilu had in 2017 discovers government spending on healthcare lowers the infant mortality rate, and 1% increase in state level can lead to a net domestic productivity in public health spending in association with the reduction in the IMR of roughly 9 infant deaths per 1,000 lives. So here we can see that his study also found out that increase in public expenditure leads to reduction in the IMR, infant mortality rate. So the objective of the current study is to identify the trend of infant mortality rate in last 60 years. And to understand the relationship between infant mortality rate and growth in India. And third objective is to analyze the effect of health expenditure on IMR. So to continue this study, 3 hypotheses are formulated. First one is the null hypothesis state that trend of IMR has not reduced in India in last 60 years, and then the trend of IMR has reduced. Then second hypothesis is IMR of a country has not been affected by growth rate. And next is IMR of a country is affected by growth rate. And nextly, health expenditure does not reduces IMR, and health expenditure reduces IMR. So these are three hypotheses which which we have formulated, and then based on that, conclusion are also made. So when we talk about data collection, the data is based on the secondary source where we have collected the data from various reports published by World Bank, Government of India, and as well as Ministry of Health. In this paper, we have taken data from of the last 60 years. So from 1960s to 2020, the data on IMR, GDP has been collected, growth rate has been collected, and as well as for talking about health expenditure, we have collected the data of last 20 years. And then to draw the conclusion, we have used correlation, p-value, and also we have run the multiple linear regression model. And to run this regression model, we have used the advanced tool, stratigraphic software, as well as the advanced Excel. The methodology used is to identify the correlation between infant mortality rate and growth rate, and second is correlation between infant mortality rate and health expenditure. And then we had run the regression model where dependent variable is IMR, and it is a multiple linear regression model. So there are two independent variable, namely growth rate and health expenditure. So this is the table of last 60 years of the data which we have collected, growth IMR, growth rate, and 20 years health expenditure and growth rate. So entire data is there. And as you can see in the bottom, air resources is also noted. Now talking about when we look at the IMR data, you can see that IMR from 1960s to 2020 has fallen down considerably, and it is falling gradually, which indicates that India is developing, because infant mortality rate over per thousand heads is going down. Now, when we talk about is there any relationship between growth rate and health expenditure? So yes, you can see that there is a purple line which indicates health expenditure, and pink line indicates growth rate. So you can see that purple line, health expenditure in India as a whole, we know that health expenditure is less than 2% of the GDP. So it is continuously reducing. But despite that, you will observe that there is some type of parallel movement between the IMR and growth rate. Look at this one. Health expenditure increased, IMR also reduced. Health expenditure is reducing, IMR is reducing. Health expenditure is further going up, IMR. So that we can see that there is a relationship between both. However, in 2008, you can see that that growth rate had went down drastically. So here there are other parameters, that is global financial crisis. But majorly we can see that there is a relationship between growth rate and health expenditure in a country, in India. And that is being concluded based on the last 60 years data. And this is, I have used the stratigraphic software for it, and this shows the infant mortality rate and predicted infant mortality rate. So here, these are the different dots which are representing in IMR and predicted IMR. And here also you can see if this represent health expenditure line fit plot, and also predicted infant mortality rate. So both of them are mentioned here. We can see that the movement between the actual IMR and predicted IMR is quite similar. So prediction has been most of the time quite right. Now let us understand the correlation which we have collected from found out from the tools used by us. So this table indicates the relationship between public expenditure and time. So here you can see that public expenditure in last 60 years has gone down, but we can also see and further you can see that growth rate, so it is in minus, which is indicating that public expenditure is reducing, but there is a considerable public expenditure. The second is you can see that growth rate is positive. So over the time we can see that in India, economic growth, with the time economy is growing. Over next, there is we can see that there is a correlation between health expenditure and growth rate, which is there is a negative correlation. And this table indicates the last 60 years IMR growth rate, relationship between year IMR and growth rate, where you can see that in last 60 years, infant mortality rate has gone down. So infant mortality rate has gone down by 99%. And there is a positive correlation between growth rate and time. So again, it is showing that over the period of time in last 60 years, Indian economy has grown. It is a positive indicator for our country in last 60 years. So you can see, we can see that there is an inverse relationship between IMR and growth rate, and which is very much true theoretically as well as practically. With the data, it is also true that it means that when IMR goes down by 100%, then Indian economy grows by 26%. So there is a negative relationship, and which is very much true. Fall in infant mortality rate leads to rise in growth rate of a country, and that is being proved with the help of this correlationship. And we can also show this with the help of the multiple linear regression model, where IMR is a dependent variable and alpha is constant minus. So in a country, there will be some amount of mortality rate.
Sorry for interrupting you. We are running short of time. Can you go to your conclusion, please?
Yeah, sure. So after identifying all this hypothesis, the conclusion which is drawn is, in last 60 years, IMR has reduced considerably. The IMR with the time has a very high negative correlationship. That is, it has gone down, which indicate Indian economy has grown. IMR has a low IMR with growth has a low negative correlationship, and public expenditure has been high positive correlation with IMR. It indicates that increase in health expenditure in India will lead to fall in IMR. And over the period of time, though in India health expenditure has reduced, but there is a need to increase health expenditure by the country, and IMR is affected by health expenditure and growth rate of a country. So these are the various references we have used, and the various research paper, and the data is collected from the authentic sources. Thank you so much.
Hello, Neha.
Yeah, hello.
Very beautiful presentation. I was very much impressed by your language.
Thank you
The way
so
you
much.
can you tell me the reasons or why you were so interested in selecting this topic, IMR, for this international conference?
I'm really glad to answer this question, because we are the nation with the highest second populous country in the world. So human dividend, we are moving towards human dividend. So definitely when we identify the causes of IMR, so ultimately we are leading towards productivity, increasing the productivity. And how can we make our country to be more productive and improve the quality of life of the people? That's very important. So fall in IMR directly indicates that life of people is increasing, and we are boosting our demographic dividend.
Okay, thank you so much.
Yeah, thank you so much, ma'am.
Thank you, Neha.
You are most welcome, ma'am.
Participant is Kalaivanan D and S. Tamilarasan. Kalaivanan D and S. Tamilarasan. This is your last call. Kalaivanan D and S. Tamilarasan. Okay, next, M. Bhagyalakshmi.
Hello. Hello.
Yes.
Hello.
Yes, we can hear you.
Yes, ma'am. I'm Rajalakshmi. My name is not mentioned in the list, but I am going to present, ma'am. I have only 5 minutes, ma'am. Actually, we are here in a conference, ma'am. So can I present, ma'am? Hello, ma'am.
Yes, yes.
Yeah, ma'am, you can, you're not there in the list.
Yes, ma'am. Now only I talked to the ma'am, her number is given in the voucher.
Okay, you can go with your presentation.
Okay. Okay, sir. Thank you, sir. Actually, my topic is public expenditure on health, a study with reference to COVID-19 pandemic. And I'm a research scholar of Madrid Cambridge University. I'm going to present a topic on expenditure during the pandemic. Public in the pandemic, we know that COVID is almost affect all the sector. So, but it mostly affect the health sector and the health sector. So, and during pandemic, health expenditure of the
Excuse
government is the hello. Yes.
Rajalakshmi, your PPT is not visible to us.
Yes, ma'am. Now we can't say, ma'am. Actually, we are in a conference, so actually we won't have laptop. So can you present without PPT? Yes, ma'am. Hello, ma'am.
Continue, it's okay.
Okay, ma'am. Thank you, ma'am. And the and the expenditure has increased rupees 2.73 lakh crore in crore which was in the 2019 to 20, but during the COVID-19 it increased 4.72 lakhs in the 21 to 22 year. Then we know that even that government expenditure increases, but the we can find the shortages of healthcare facilities. Also, we need to improve more. Making the policies to improve the health expend to improve the to come back from this COVID-19 period health shortages. Yes, ma'am. Hello, ma'am.
You're audible.
Hello,
You
ma'am.
can. Rajalakshmi.
Yes, ma'am. Ma'am, two more presenters there, ma'am.
What
Ma'am,
happened?
actually, we have only two minutes, ma'am.
Okay, okay. You finished?
Yes, sir. Sir, actually, my topic, I have to correct my topic. So I want to correct. So can you write my topic again, sir?
You want to correct your topic?
Yes, yes, sir.
Yeah, that you can send a message later. Yeah. Okay.
Okay, sir.
Thank you.
Thank you.
Thank you, Rajalakshmi. The next participant is Anchal Verma.
Hello, ma'am. Can you hear, ma'am? Ma'am?
Anchal Verma, is that you?
Yes, ma'am. Yes, ma'am.
You can start with your presentation.
Yes, ma'am. சொல்லடி Hello, ma'am.
You're audible.
Ma'am, I'm Vinodini, ma'am. Hello, ma'am.
Sorry, who is this?
I'm
Excuse-
Vinodini, ma'am.
Now, Vinodini, you please wait. It's now Anchal Verma who is going to present. We'll call you again. Anchal? Yeah.
Sorry, sir, I'm unable to present my PPT.
Correct.
Can I say like that without presenting?
You want to present without presentation.
Actually, I can't share my screen, sir. Some technical problem is there.
Okay, but you can start your presentation, no problem. Without PPT.
Yes, sir. Yes, sir. Good afternoon, everyone. Myself, Anchal Verma. I am a student of St. Anne's College for Women, and today's topic is measures to improve infant mortality rate. What is infant mortality rate? Infant mortality rate is the probability of a child born in a specific year or period during period dying before reaching the age of 1. if subject to age-specific mortality rate of that period. Infant mortality rate is a probability of death derived from a life table and expressed as rate per 1,000 lives per birth. What are causes of infant mortality rate? Preterm births, intrapartum related complications like lack of breathing at birth, infections and birth defects. The main causes of death are pneumonia, diarrhea, malaria. Malnutrition is underlying contributing factor, making children more vulnerable to severe diseases. How is IMR measured? It is like civil registration, number of deaths at age 0, and population for the same age are used to calculate death rate. Census and surveys. An indirect method is used based on questions to each woman of reproductive age as to how many children she has ever born and how many are still alive. How is it estimated? The interagency group for infant mortality of estimation, which includes representatives from UNICEF, WHO, the World Bank, and the United Nations Population Division, produces trends of infant mortality rate with standardized methodology for a group of countries depending on the type and quality of source of data available. What are the essential newborn care given? First is thermal protection. Next, hygienic umbilical cord and skin care. Early and exclusive breastfeeding, preventing treatments. The family should seek prompt medical care if the newborn has reduced activity, difficult breathing, fevers or convulsions, or feel cold. Register the birth, bring the baby for timely vaccination according to the national schedule. This is the 2019 child mortality rate of the world, and the highest is in African countries. What are the WHO responses to increase the infant mortality rate? Improve infant mortality rate. Strengthen and invest in care, particularly around the time of birth and the first week of life. Improve the quality of maternal and newborn care from pregnancy to the entire postnatal period. Expand quality service for small and sick newborns, including through strengthening neonatal nursing. Reduce inequities in accordance with principles of universal death coverage, including addressing the needs of newborn in humanitarian and fragile settings. Infant mortality rate in Indian states. The highest is in Uttar Pradesh, Odisha, and Assam, and the least is in Kerala. Measures taken to reduce infant mortality rate. The National Health Mission has taken the following measures. Promotion of institutional delivery through Janani Suraksha Yojana. Promoting institutional delivery by skilled birth attendants. Setting up facilities for care of sick newborns, such as special newborn care units, newborn stabilization units, and newborn care corners at different levels in a thirst area under NHM. Various training centers for being conducted under NHM to train doctors, nurses, and ANMs for early diagnosis and case management of common ailments of children and care of mother during pregnancy and delivery. These trainings are on integrated management of neonatal and childhood illness. Navjat Shishu Suraksha Karyakram, skilled birth attendants, life-saving anesthesia skills, comprehensive emergency obstetric care, basic emergency obstetric care. Nutritional rehabilitation centers have been established for management of severe acute malnutrition. Appropriate infant and young child feeding practices are being promoted in convergence with Janani Sishu Suraksha Karyakram. It entitles all pregnant women delivering in public institutions to absolutely free and no expense delivery, including cesarean section. The initiative stipulates free drug diagnostic, blood and diet, besides free transport from home to institution. Home-based newborn care to Ashas have been initiated by providing incentive of rupees 250. The purpose of home-based newborn care is to improve newborn practices at the community level and early detection and referral of sick newborn babies. The main objective of this presentation is to gain knowledge about the economical, social, and medical conditions in which our Indian state children live, and also to increase the human resources, because the human resources can only be increased by promoting essential care given to newborns. It leads to healthy growth of children. Thank you.
Yeah, Anchal Verma, you were
Yes,
talking
sir.
about government scheme, no, for the infant
sir.
mortality. Yeah, can you tell a little more on that? What is that scheme? That central government scheme is there, no?
Yes, sir. That is Janani Suraksha Karyakram, Shisu Suraksha Karyakram. It is all about given by Ashas and hospitals, any hospitals like government or private, to the newborn and the mother, which helps like giving vaccination after the birth, which immunizes the child like vaccines of hepatitis, the cholera, and which immunizes the child. Thank you, sir.
Okay, thank you, thank you.
The next participant is Kalaivanan D and S. Tamilarasan. Next, Surabhi M. Raul and Balaji B. Suryavanshi. Surabhi M. Raul and Balaji B. Suryavanshi. The last call, Surabhi M. Raul and Balaji B. Suryavanshi. The next participant is T. Saranya and M. Dharani. T. Saranya and M. Dharani is your last call. The next are Narmada B. Priyadarshini and C. Santya. I repeat it once again. R. Narmada B. Priyadarshini and C. Sandhya. The next participant is J. Deep. Pavitra. Pavitra, please wait for your turn. The last call, J. Deepti.
Yes, ma'am. I hope my voice is audible and my presentation is visible.
Yes, your presentation is visible and your audio is clear.
Hello, ma'am.
Yeah, Deepti, can you just put it in full screen mode?
Hello, ma'am.
Good afternoon, all. Specialized in Caucasian technology in Sri Ramachandra Institute of Higher Education and Research. My topic is on enhancement of positive mental health and cardiovascular well-being. So health. Health, according to the World Health Organization, is a state of well-being, complete physical, mental, and social well-being, not merely the absence of disease and infirmity. The health is not only about the physical part of your body, but also the mental health and your social behavior towards the environment and towards the individual. So according to the World Health Organization, the main determinants of health include the social and economic environment, the physical environment, and the person's individual characteristics and behavior. So the health always follows the three important tasks, that is the social, mental, and physical. So what are the underlying determinants or factors for the person to be healthy or unhealthy? So the key factors are the income and social status, education and literacy, social environments and physical environments, biology and genetics, healthcare services, gender, social support networks, and healthy child development. And as you see, health and mental health always correlate with each other. Always correlate with each other. So when your mental health is positive, or when you're happy, when you have positive emotions, you always do great works, great achievements. Whereas in vice versa, when you have the negative emotions like depression, anxiety, you tend to be weak, lazy, or even sleepy. You don't do anything in that period of time. So first, what is mental health? The World Health Organization, that is WHO, describes mental health as a state of well-being in which an individual realizes his or her own abilities, who can cope up with the normal stresses of life and can work productively, who can able to make contribution to his or her community, which is nothing but the work-life balance. So the mental illness is described as the spectrum of cognitive, emotional, and behavioral conditions that interfere with the social and emotional well-being of an individual and the productivity of the people. So having mental illness be permanent or temporary, which can impair the mental functioning of the person. So the other terms for mental illness are mental disorders, mental dysfunction, mental health problems. As you see, the topic is about cardiovascular health and mental health well-being. So cardiovascular health. Cardiovascular health refers to the health of the heart and the blood vessels. Cardiovascular disease is a group of disease of the heart and blood vessels, including the coronary artery disease, stroke, heart failure, heart arrhythmias, and heart valve problems. Most of the common heart disease, which cause due to the accumulation of cholesterol or fat deposits, or even plaques in the coronary arteries that present in the heart, which supplies the blood to the heart. So how can this cardiovascular health and the mental health correlate? There are 7 metrics of cardiovascular health, that is smoking, diet, physical activity, body mass index, which we basically call BMI, blood pressure, cholesterol, and fasting glucose. These 7 metrics get affected due to the mental health. The correlation between the mental health and the heart. The negative emotions like depression, anxiety, even stress is the most common in coronary artery disease patients, which impede the increased risk of further heart problems. And the term cardiovascular disease refers to the diseases like heart attack and angina, which is nothing but the heart block. So as you can see, many people who intend to have negative mental health, or who do not have good mental health well-being, tend to take some medications to reduce their anxiety, depressions, and that medications can tend to increase the risk of cardiovascular metabolic diseases. So being positive, being optimistic, and being positive affect the necessary of positive life. Even though the positive and negative mental health qualities are inversely related, being positive well-being predictor of subsequent health outcomes after controlling for depression, could increase the cardiovascular health. So as you see, the cardiovascular health is improved by the 3 mechanisms. The effect of positive psychological well-being is also influenced by 3 mechanisms, that is biological pathway, behavioral pathway, and psychosocial pathway. The biological pathway, psychological factors lead to the specific biological alteration when the anger or hostility or when the negative emotion takes place in your brain. So this angry or anxiety gets associated with the increased platelet aggregation, which leads to the inflammation, which activates the hypothalamic pituitary adrenaline, which results in the increased risk of cardiovascular health. As you can see, the inflammation is one of the well-recognized reasons for cardiovascular health risks. This can be prevented by positive mental health well-being, which also increases the positive biological pathway. The second one, behavioral pathway. It depends upon the individual behavior or to the society. The negative psychological health, such as depression, anxiety, stress, or PTSD, that is post-traumatic stress disorder, associated with smoking, diet, lower physical activity, and obesity. As you can see, this behavioral, the main part of the 7 metrics of cardiovascular health gets affected in behavioral pathways. Third,
Deepti, can you give a conclusion? Yeah.
Just one more slide, sir.
Oh. No, because we're running short of time.
Yeah, just
Can
one
you-
more minute, sir. So the positive, how could a positive mental health correlate with cardiovascular health? As you see, the positive emotions like happiness, emotional visibility, optimism, gratitude, and psychological well-being tend to satiate the smoking, increase the physical activity, healthy heart, and weight loss, which tends to increase changes in the behavioral, psychological, and biological process that decreases the LDP, VLDP, that is low density lipoprotein. As well, in vice versa, the negative psychological health like stress, anxiety, and anger and hostility initiates the smoking, which initiates the smoking, physical inactivity, poor eating, and overeating, which influences the aggregation of platelet, thus forming the risk of CVH, that is cardiovascular health. As in conclusion, and the need and significance of my paper is good nutrition, daily exercise, and adequate sleep are the foundation of healthy living. And at least you should get 6 hours of sleep. When the body and mind are fit, it results in happy and healthier heart. If any, and try to keep your mind calm in every situation. And music is one of the most effective therapies for overcoming bad emotions. It also relaxes muscles and reduces stress. So if anything fails and you have trouble managing mental health, the final opinion is to seek the professional. Thank you. Thank
Hello,
you, sir.
Deepti.
Hello, ma'am. Good afternoon, ma'am.
Good afternoon. Very beautiful presentation.
Good evening, ma'am.
Yes.
Good evening,
Usually
ma'am. Excuse me, ma'am.
Sheila, wait for your turn.
Yes, Deepti is there.
Yes, ma'am.
Actually, we say in order to have a good heart, we should eat healthy. We should exercise properly, maintain good diet and all those things. But it was really very interesting to hear from you that our mental health also plays a very important role
Yes,
in
ma'am.
maintaining a good heart. In this world,
I'm sorry,
we
ma'am. There's
have-
a technical issue. 1 second.
Okay. Can you hear me now? Yes. Am I audible? Okay, thank you. Thank you, Deepti.
Good evening, ma'am. I am Atmata. I can start, ma'am.
Sheila, wait for your turn, Sheila. We will call out.
Okay, ma'am. Okay.
Okay, ma'am.
Please mute your mic.
Mute.
Ma'am, am I audible?
Yes, you are audible, Deepti.
I'm sorry.
Recording in progress.
Thank you, Deepti. All the participants are requested kindly fill the form that is in your chat box. Every participant. The next participant is yes, Indra Devi. Yes, Indra Devi. Yes, Indra Devi, this is your last call. The next participant is Neha Mary Matthew and Sunita Yasampalli.
Yes, ma'am.
Please start your presentation.
Yes, ma'am. Ma'am, I'm not able to share my screen, ma'am.
Deepti, kindly close your presentation.
Once again, ma'am.
Yes, am I audible, ma'am?
You're audible and your presentation is visible. Start your presentation.
Okay, ma'am. Good afternoon, everyone. My name is Neha Mary Matthew. I'm a first-year student in BA Economics in St. Anne's College for Women, Hyderabad. My research topic is health status of children in India. I focused on malnutrition as it is one of the major health problems faced by children in India. Aim of this paper is to estimate the health status of children and to identify the factors for undernutrition among children in India. India being the second populous country with a 1.21 billion population comprising 13.1% of child population under the age group between 0 to 6 years. Despite the various improvements in economy, India hosts the highest number of malnourished children in the world. Child health can be defined as a state of physical, mental, intellectual, social well-being, and not merely the absence of disease or infirmity. Children are tomorrow's nations. Healthy children are more likely to be healthy adults. Among children, there is high mortality rate with significant differences in child mortality both between and within different states. Health indicators such as growth, nutrition, and healthcare access affect children morbidity and mortality. Many socio-economic and environmental factors such as mental education, income, access to clean water have been shown to influence them.
Neha Mary, I'm sorry to interrupt. We are running short of time. So can you straight away go to your findings and...
Oh, sure, sir. So these were some of the literature review that the previous studies conducted. So major determinants of child malnutrition under 5 is poverty, socioeconomic and demographic factors, breastfeeding practices, immunization, role of mother. These are various steps that was taken by the government for the improvement of health of children. So some of the recommendations for preventing malnutrition among children, providing nutrition supplements free of cost, giving nutrition education, making them understand the importance of taking nutritious food and supplements during the pregnancy period itself, providing potable water and proper sanitization facilities, nutrition and healthcare campaigns should also be included. The provision of universal education alongside universal access to healthcare, infant vaccination program, vitamin A supplement program, childhood treatment disease will have an impact on the reduction of child mortality rate. So conclusion, malnutrition among children is a complex challenge which cannot be solved by emphasizing only on economic growth. Policies which emphasize on gender parity and empowerment integrated in healthcare policies will have a positive impact on nutrition level of children. India has made progress in tackling hunger and undernutrition, though the success rate to prevent malnutrition is not yet satisfied. With sustained prioritization, increased resource allocation, strengthening the schemes provided by the government and holistic approach with good governance will have a positive impact for the prevention of malnutrition among children. In short, nutrition and education are the basic elements to modernize a community. Systematic administrative reforms should be implemented in the food distribution system and in awareness programs. Thank you.
Thank you, Sneha. Thank you so much.
Thank you, sir.
Participants, I request you to kindly shorten your speech or presentation to 3 minutes. Do not exceed 3 minutes. The next call is Anuradha Paul and V. Sudhasini.
I presented.
Good afternoon, ma'am. I'm ready to present.
Who is this?
Anuradha Paul.
Okay, you can start your presentation.
I think I should mute.
My topic is a study on COVID-19 vaccination in India. COVID-19 is a novel coronavirus that had not earlier had been identified in humans, which began in the city of Wuhan, China in December 2019. As of April 19, 2022, there are nearly 505 million global cases of COVID-19. Almost 457 million people had recovered from the diseases, while there had been 6.2 million deaths.
You introduce that.
In my present paper, the objective of this paper is to the types of COVID-19 vaccines available in India and to analyze the process of vaccination drive, status of vaccination in India. Methodology of this present paper is to achieve these objectives. The study uses secondary data. The present study uses vaccination data for 16 January 2021 to 18 March 2022. Statistical tools like line graph used for analysis of data. The study uses weekly vaccination data, weekly age-wise vaccinations. Vaccination data collected from the dashboard of CoWIN India website. Result and discussion of this paper. Status of COVID vaccine in India. Vaccination in India are administered since January 16, 2021 with the administration of vaccines to all healthcare workers in the first phase of the vaccination campaign. In India, this is the first free vaccine campaign for all citizens. In India, this is the in February, the vaccination program was extended to cover the frontline workers. The second phase of the program began and included citizens above the age of 60 and subsequently people above the age of 45 with comorbidities. India's vaccination program includes 3 vaccines, namely Oxford University AstraZeneca Covishield vaccines manufactured by the Serum Institute of India, Bharat Biotech Covaxin, and Russia's Sputnik V. The third phase of the program included the people above age of 18. The fourth phase of the program began in January 2022, which included the people below age of 18. Out of 1 billion COVID-19 vaccine administered, over 1.4 billion vaccines are Covishield vaccine produced by the Oxford University and AstraZeneca as of February 28, 2022 in India. March 22, nearly 179.48 crore population has been vaccinated. In my paper, I have put a line graph that is for vaccination trend in India. I have there is an inflection. If this graph we see there's a fluctuation in the COVID vaccines has been taken by peoples in India, and age-wise vaccination in India. In that interpretation, we can say that there is a fluctuation in age-wise vaccinations. When people are aware, that time people in the conclusion of this study, vaccines are a vital weapon in the fight against COVID-19 and using the resources has strong public health and life-saving benefits. Many states have adopted door-to-door vaccination to avoid super spreading and to assist the nation mass vaccination efforts. Vaccine hesitancy must be tackled by awareness campaign at the village level. Looking at the emerging SARS-CoV variant, the government have to focus on maintaining a high vaccination pace and coverage with a double dose of COVID-19 vaccine and a shorter time between doses so that high efficacy rate can be attained in the whole population in India. Thank you.
Yeah, thank you, Anuradha. Thank you so much.
Thank you, sir.
The next participant is T. Sangeeta and K. Jagadish.
So good afternoon to all. Ma'am, am I audible and my screen is visible?
You're audible and your screen is visible. Can you please state your name?
I'm Dr. T. Sangeeta, author, along with Dr. K. Jagdish is the co-author of the paper.
Okay, you can continue your presentation.
So the title of the study is Mobile Phone Addiction, a Threat to Mental Health of Educational Stakeholders in India. More than 70% of Indians feel smartphone usage will affect mental health. This is the news from The Hindu, December 14, 2020. So we all know in present scenario, we are living with the mobile phones and we cannot think about a day without mobile phones. So from day to dawn, people are engaged with mobile phones, especially the teens, college goers, as well as the teachers. So they are busy in the digital world than the real world. Due to this, mental health gets affected badly. So the need and significance of this study is to find out the mobile phone addiction among the stakeholders. Here, I mean the stakeholders are the students, college students, school students, teachers, and even the administrators of institutions. Due to the usage of mobile phones, firstly, many of the students are into the trouble of cyberbullying and are also exposed to some kind of cyber crimes. The mind gets disturbed due to the usage of mobile phone throughout the day, and which may result in lack of mental health and lead to mental illness. The objective of this study was to construct and validate the mobile phone addiction among education stakeholder scale, to find out the level of mobile phone addiction among educational stakeholders, and to find out whether there is any significant difference exist among the mobile phone users, the educational stakeholders, in respect to gender and type of institution. The hypothesis is there is no significant difference in the mobile phone addiction among educational stakeholders concerning the gender as well as type of institution. The research instrument is constructed and validated by the investigators with 27 items. The reliability and validity are specified. The population was a random sample with 226 educational stakeholders such as students, teachers, researchers, professors, and administrators are used for the study. A simple random sampling technique has been applied for the study through Google Form. Data was collected through Google Form. So the finding states that the level of mobile phone addiction among educational stakeholders in India is moderate. Yes, we all do use mobile phones, and it is found to be moderate among the educators and the stakeholders in the field of education. There is a significant difference in mobile phone addiction among educational stakeholders concerning gender, where we found that male educational stakeholders are much more when considering the usage of mobile. There is a significant difference in mobile phone addiction when concerned with the type of institution, in which college stakeholders are more addicted to mobile phone, followed by the university and school stakeholders in education in India. So implications of the study, yes, raising awareness of mobile phone addiction will enhance positive mental health in colleges and schools and universities. So one of the findings states that male stakeholders are more addicted. So educational administrators and policymakers should orient the male stakeholders specifically to give the awareness about mobile phone usage and improvise their mental health. Another finding states that college stakeholders are more addicted to mobile phones, followed by university and school stakeholders. So the management as well as the government has to take major steps to introduce strict policies and government GOs to restrict the usage of mobile phones in school and colleges. Various intervention strategies can be adopted to create awareness on mental health and about the mobile addiction. So the entire management, school, college, and universities should organize workshops, seminars, and conferences for teachers and students related to the problems of mobile phone addiction and the need for mental well-being. So the suggestions and recommendations are: the authorities, mental health counselors, and NGOs should collaborate to create awareness among parents, teachers, through training workshops to gain mental health and physical health. Policymakers should introduce curriculum to know about the technology and the usage of technology with values. Teacher training programs should be introduced where already we have the ICT in curriculum, and there must be few more syllabuses added where to balance the other engagement in schools along with the ICT and use ICT and mobile phones and such technologies in a very perspective, in a positive way. So time constraints should be given to the students for usage of mobile or usage of the internet. The study clearly shows a picture of how mobile addiction would kill our time and affect the mental well-being of an individual. The teachers and parents have to be responsible citizens. They should start from their end to avoid the usage of mobile phones. As we know, a story, two of them traveling in a train, a mother and a child. So the child was reading a book. So one fellow asked the mother, how is that your child is not playing video game or just not wasting time, he is reading book? So the mother said, I have the habit of reading book. So by seeing me, my son is reading the book. So we stakeholders, educationists are the real-time examples, role model for our students. So what we do, the students will follow, and they just take it up from us. So we teachers, teacher educators should take steps to see to that we use mobile only for the purpose needed, or if it is needed, not to waste our own time in the mobile phones, so that seeing that our students also do not get that kind of attitude. So they should advise the students on the same line and gain mental health for mental well-being. Thank you.
Thank you, madam. Thank you so much.
Thank you, sir. Do I have any questions, sir?
No, madam, it is clear. Thank you very much.
Thank you so much, sir. Thank you.
Participants, kindly shorten your PPT presentation to 3 minutes. Do not exceed 3 minutes, please. The next participant is T. Sangeeta and Deepti Ranga.
Hello. Hello. Good afternoon, ma'am. Am I audible?
Good afternoon, Deepti. You can start with your presentation.
Okay. So our topic is reclamation in the health sector and is the panacea of care economy. Myself, Deepti Ranga, and I am from Central University of Rajasthan, and I have written the paper under the guidance of Dr. T. Sangeeta ma'am, who is an associate professor in the Department of Education in Central University of Rajasthan. Ma'am, it's not working. Yeah. So our paper focuses on to describe how much important role care is playing in the enhancement of the health sector as well as the economy. The word care seems quite simple because it is used in our day-to-day life, but we never knew that it is actually the essence of economy. Just as salt present is not valued in food, but its absence makes the food tasteless. Similarly, the care is. The care done by a mother, a father during their exam, providing food to their bed. This example we can see in our day-to-day life. But if these kind of care is stopped happening or stopped working, then the child can't perform well. The same concept is applied to the elders also. In this way, the person will be healthy and he will be performing well and thereby contributing to the economy as well. This was also proved in the pandemic. The need and significance of care economy. Without this, the productivity of a person gets reduced. A small amount of care can bring a lot of difference. Paid care is often taken care of, but the unpaid care brings more miracle to the economy. There are types of care work. The first is direct care. Direct care, as the name suggests, it is directly taken care. The examples are care to the elderly person, disabled person, or patient. Second is indirect care. Example of indirect care are like government providing subsidies to the poor for their upliftment. The third one is supervised care. It is something which remains unpaid most of the time. That is parental care. Next is health is wealth. There is a Gujarati proverb which states that first happiness is health and second is full stomach. When a person is healthy, he will contribute to the economy in an efficient manner. When the care workers in the society are given importance and their work is valued, then it will not only improve the economy, but also the living and well-being of the healthcare workers. There is a report which was presented by the International Labor Organization.
I'm sorry, Deepti, I'm sorry to interrupt. We are running short of time. Can you straight away go to your findings?
Okay, sir.
Thank you.
So I would like to conclude by stating the quote from Leo Buscaglia. Too often we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around. Our paper basically focuses on how the care which is provided by the parents or by the care workers, how it contributes to the economy. Oh, that it is. Thank you, sir.
Thank you, Deepti. Thank you so much.
The next participant is
Yes.
S and T Indra.
Good evening to all. Ma'am, can you audible?
Yes, you are audible.
Good evening to all. This is Sheila from Madurai Kamaraj University. My paper, Sanitation and Women Health. Introduction. According to World Health Organization.
Your presentation is not visible.
Yeah, ma'am, I don't share in the PPT, ma'am.
Okay. The time limit is 2 minutes.
Okay, thank you, ma'am. According to World Health Organization, better health is central to human happiness and well-being. It also makes an important contribution to economic progress. As a healthy population's lives longer is more productive and save more. Rural women have limited access and opportunities to make use of the healthcare policies. Rural women faces various kind of problems such as maternity, lactating, reproduction, malnutrition, and very big issues on sanitation. I have framed 2 objectives. First one is to study the rural woman health, and second one is to study the improvement of cleanliness in rural areas through solid and liquid waste management. I have used to secondary data. It took a national annual rural sanitation survey. This survey aims to accelerate the efforts to achieve universal sanitation coverage and to put focus on safe sanitation. The Prime Minister of India launched the Swachh Bharat Mission on 2nd October 2014. Swachh Bharat Mission aims to achieve Swachh Bharat by 2019 as a fitting tribute to the 115th birth anniversary of Mahatma Gandhi. It leads to open defecation free, clean and sanitation. It aims to It's having two objectives: no visible faces found in the environment or village. And second one, every household as well as public community institution using safe technology disposable of faces. I have to conclude. My paper highlights the intact potential of initiatives that seek to address of rural women health through the safe and hygienic toilet usages, Swachh Bharat missions to improving the levels of cleanliness in rural areas through solid and liquid waste management activities and making Gram Panchayats open defecation free, clean and
Sheila ma'am, can you just finally go to a conclusion?
Yes, sir. I telling about the conclusion. Hello.
Yeah. Okay, ma'am, you can conclude. Thank you.
Good for rural population using safe and hygienic toilets. It leads to give a good health for rural population, in particularly rural women. Thank you.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, sir.
Good afternoon, sir. Good afternoon, sir.
Sorry, who is this?
I'm Vinodini, ma'am.
Yeah, you can continue. You can start with your PPT.
No, ma'am. Only I presented. I don't have shared the PPT, ma'am.
It's okay, Vinodini. Start your speech.
I'm P. Vinodini, School of Economics, Madurai Kamaraja University. My topic is socio-economic and health condition of women agriculture workers in Madurai district of Tamil Nadu. Introduction. Rural women play a protective role in agriculture. They got involved in the entire process like plucking, sowing, weeding, applying fertilizer, harvesting, weaving, packing, loading, and a related occupation like livestock management. Women does the work in the agriculture field and also does all the domestic chores, house liking, cooking, cleaning, washing, take care of child and elders, etc. Its plots of contribution women face innumerable issues and struggles, both in the workplace and the house. Women are generally treated as secondary citizens in our nation, and they are contributing 25% of GDP in the increasing being a female activities, and they employing fourth third of all economic activities. Women in the country. Then I have collected in a 10 review of literatures. Then objectives to study the socio-economic condition of women agriculture workers and to understand the general health issues faced by the women agriculture workers. Then methodology. The study area is Vadapalanchi village of Madurai district, which is protectional agriculture area located in the region of Tamil Nadu. Vadapalanchi has the population of 2,518 among 128 male and 1,025 are female. Census of 2011, the village has been selected. They considered the geographical located. Total population, women population, primary and secondary occupation of the village, prevailing health facilities and accessibility in availability of social security. And then findings. Age is one of the basic biological characters of the person who is along the interpret of the important bearings, physical and psychological well-being of women agriculture workers. Then 31 to 40 years, there is a concluded relationship between the marital state and head of the family is the 24% and widowers and 23.2% headed by the women.
Vinodini, your time is running up. Please conclude. Please start your conclusion.
The health issues and terms of the given required attention of the since the health and directly linked to the agriculture production, it is needed of the hour of consider the health issues, agriculture workers and public health and government should preferably revise the existing health policies. Thank you, ma'am.
Thank you, Vinodini. Thank you.
The next participant is Zaid Khalid. Zaid Khalid.
Hello.
Hey,
Yes,
Leah.
it's Khalid. Can you hear me?
Yes, I can hear you. Start your presentation.
Yes. Just give me a moment.
Zaid Khalid, you can start. Okay.
Yes, can you see my screen?
Yeah.
Okay. So good
Can you
morning. Yes, good evening, everyone. My name is Zahra Khalid, and I'll be presenting the paper on investigating anxiety in women with emphasis on their social and economic environment in the urban areas of India. So beginning with the introduction, about 64 years ago, World Health Organization had given us this holistic definition of health, which is called a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So since then, endeavors have been made in order to actualize health the way it is defined, that is in a multidisciplinary form. So health does not only encompass the physical aspect, but also the mental, emotional, and social. Now, coming to gender, why we're taking gender as a determinant of health is because gender is a social construct that refers to the characteristics of women, men, girls, and boys. It plays a crucial role in determining the health of an individual as it influences people's experience of and access to healthcare. The way that health services are organized and provided can either limit or enable a person's access to healthcare information, support, and services, and the outcome of those encounters. Now, in the case of women, mostly gender biases, they act as a barrier more than acting as a helper. Now, why is it a barrier? Is because we all know how women face restrictions in mobility. There's lack of access in decision making. There's lack of power, lower literacy rate, discriminatory attitudes of communities and healthcare providers, lack of training and awareness amongst healthcare providers, and health systems of specific health needs and challenges of women and girls. Now, to infer and to deduce the same, I conducted a survey which had about 300 women, wherein 58.3 women, they saw health as a state of physical well-being only. And the 53.3%, they said that yes, mental.
Sarah?
Yes, ma'am.
Please conclude your speech.
Okay,
Please conclude.
The screen is still on first page.
Oh, it's still. Can you see it now?
Still on first page.
Let me share it again. Can you see it now?
Yes, thank you.
Right. So I would like to conclude is that from the various findings that I had taken various determinants, that was the annual income, the age, the region, to study the geographical aspect, anxiety, and if they saw their political, social, or economical background as a cause of their anxiety. So from these findings, what I deduced was that even though most women, they did not report any physical illness or disease, they had reported the large group of these women faced anxiety on a regular or daily basis, to the extent that it had physical manifestations. Like a lot of them had headaches, nausea, upset stomach, couldn't concentrate, insomnia, etc. And thus, by the standards of World Health Organization, we cannot deem or call these women as healthy. Even though there's no physical disease or illness, these women are not healthy, which is about 80% of women that have said that they suffer from anxiety. So considering that they experience anxiety at the hands of their political, which is majorly religion for the minorities, the economic and social background, these three are a
speech, sir.
determinant of health. Sorry?
Conclude your speech, Sarah. Your time is up.
Yes. So these are the determinants of health for women in urban areas. And in order to actualize their potential as healthy individuals, we need to dwell deeper into the nuances of these determinants and ensure that their health is restored. Thank you.
Thank you, Zara.
Thank you.
The next participant is Mary Leah, CA.
Yes, yes, ma'am, I'm here.
The time limit is 2 minutes.
Yeah, okay, ma'am. 1 second. Is it visible to everyone?
Yes, it is visible to everyone.
Yes, ma'am. Good evening, respected organizers and my dear co-participants. The topic for my presentation is the impact of pandemic on the ASHA workers in Kerala with special focus on Cochin Corporation. As you all know, under NHRM, there is a very important category that is accredited social health activities. They are the community health workers and they act as a crucial link between healthcare delivery system and community. So during the course of COVID-19, these ASHA workers have become very important as they go from door to door, house to house, checking for symptoms, generate awareness, and other various healthcare programs. So this study examines the overall impact of pandemic on the ASHA workers, and it is studied in Kerala. And the study examined the difficulties of ASHA workers related to COVID-19 activities. And the main two areas which I focused was the what are the services rendered by the ASHA workers during the time of COVID-19 and the problems faced by them. And regarding the services, their services of great significance as they went door to door, educated the population about the virus and monitored the symptoms. Everything was done. And they were given training in the initial phase and they had a very good team to house a person with suspected infection. And they are working with the Kudabishri members, ward members, the Panchayat people to distribute items like handmade face mask and dizzy and other things. So that, and they become the main source of information for the government. And if any symptoms has been found out, it is their phone that rings first. So if anyone entered the ward after traveling from another place, she was the first person to know. And the district officials would prepare the route map based on the report given by the ASHA workers. The second category which I focused my study was the problems faced by the ASHA workers. Even though they were very actively involved, they were just considered as activists rather than employees. They had to visit every day about 25 houses, cover the entire distance we're walking, and they were not getting any kind of travel incentives. And they also say that they did not have sufficient masks, gloves in the initial phases, unsafe working conditions because of the inadequate protective gear, insufficient training, and lack of recognition as government health workers. Moreover, they have to carry out their normal duties along with COVID-19 duties. So they and their vacancies are not filled up, and even at their home, they also face so many risks. So the conclusion says that the ASHA workers are very important for the economy, for the society, and they conduct almost all the services, but their life is hindered because of the inadequacy. So there should be a proper awareness should be given to the community, and their role should be identified by the government, and supportive policies must be given by the government. Thank you. Thank you. Finish, ma'am.
Thank you.
Yeah.
Next participant is T. Veerapandi.
Yes, ma'am.
Please start your presentation.
I am T. Veerapandi from Hari Kamaraj University. My title is Impact of the COVID-19 Pandemic on Agricultural Production in India. Introduction. The impact of coronavirus pandemic of India has been largely disruptive in terms of economic activity as well as a loss of human lives. Since agriculture is one of the backbone of the country and a part of the government announced essential category, the impact is likely to be on both primary agriculture production and usage of agro inputs. The government has raised to purchase price of quintal of agriculture produce aimed various economic classes during the corona pandemic situation. Yet, indirect impact on agriculture households is more serious than direct impact caused by reverse migration. Farm households lost large sum of income from non-agriculture sector, which are accounted from 65% to 74% of their household income. Laid off workers in the non-agri sector who came back to their farm families must survive on agriculture income of 26% to 35%. Many farm households, particularly.
Out of time, Mr. Veerapandi, can you please go to the conclusion?
Okay, sir. Okay, sir.
Thank you.
Conclusion. As the restriction imposed due to the lockdown are being lifted, it is an opportunities movement to analyze the impact of COVID-19 on different sector of the economy. While other sectors are reported to be under significant stress, it is important to analyze the impact on agriculture and allied sector, which provide likelihood to majority of the population in India. A global food security crisis is potentially looming that cannot be countered without understanding the impacts of COVID-19 on the agriculture system, especially of the developing countries. Thank you, sir. Thank you,
Veerapandi. Thank you, Veerapandi.
Thank you, ma'am.
The next is Revati T.
Yes, ma'am. Ma'am, am I audible?
Yes.
Good afternoon, all. My name is Revati T. I'm working as an assistant professor. Ma'am? I'm audible, isn't it, ma'am?
No, Revati. Yes, it's visible now.
Okay, ma'am. So let me start. See, my topic is the Indian health insurance sector and analysis. See, I have conducted a study regarding the Indian health insurance sector with special reference to the COVID phenomena. See, beginning with the introduction, as we all know, it's the time of COVID that the importance of health insurance has become a major thought of the world. And it is in this scenario, the importance of studying the health insurance is very much essential. See, I'm not elongating my paper.
Sorry to interrupt, Revati. Can you
Sir?
just go to your objectives and then your findings?
Sure, sir. I have conducted a review of about five national and 5 international, and my objectives of the study are to study my objective is to study the current system of health insurance in India, and I want to review the functioning of health insurance system and to analyze the changing trends and challenges in health insurance sector. And this scope is providing to the analysis of Indian health insurance business. And I have adopted a descriptive methodology to the study, and I have used data gathered from various sites and publications. So this is concentrating on the secondary analysis of data. See, now I'm going to share the health insurance sector in India. See, we have about 57 insurance companies, of which 24 are providing life insurance segment and 33 belong to non-life insurance segment. Both are providing health insurance. And to discuss the phases of evaluation, first, by the arrival of employee state insurance scheme, it has been followed by central government health insurance scheme. Then first Mediclaim policy was introduced by GIC 1986. Now we have an era of competition, which is prolonged by the introduction of private players since 1999, that is post 2000. Then we have various type of health insurance policies like individual health insurance policies providing individual cover, then family floater insurance plan, which is providing floater protection to the family, then group health insurance plan, and similar such health insurance policies are available. And now, with respect to the coronavirus, we have introduced by the approval of IRDA 2 types of specific policies, that is Corona Kavach policy and Corona Rakshak policies. And these are all the 2 modern policies which is evolved recently to give protection, especially during the COVID times. This is this Corona Kavach policy. This is a standard indemnity-based policy, but this is a benefit-based policy as distinct from the Corona Kavach policy. Then, to describe the current scenario of the health insurance sector, I have collected reports from IRDA. And
can you please go to your findings?
Sure, sir. Sure, sir.
We are running out of time. Sorry.
Fine, sir. I have analyzed IRDA reports and have reached many of the conclusion that missing middle, that is the insurance although we have 57 companies providing various sorts of health insurance policies, there is a problem of missing middle. That is, a certain part of the population is not availing insurance. Although they are awesomely able to generate much income, they are not much concentrated by the government, and they are not tackled by the private insurers. Then insurance penetration is also a problem. Then coming to the findings and conclusion. See, by analyzing the secondary data obtained from various sources, we can see there is an increase in the net incurred claims ratio, and health insurance premium is also being increased. Then online insurance market, see, recently from the COVID outbreak, it is also increasing, and the problem of missing middle, that must be tackled. And Niti Aayog has presented a report regarding the handling of missing middle. That is a problem which is belonging to about 30% of the Indian population belongs to missing middle, and it must be seriously taken by the government. Then it is the need of time to get government policies to. Sure, sir.
Revati, your time is up.
Okay, so these are all the major types of conclusion I have been arrived at, and I have given references through these of the sites. Thank you.
Thank you, Revati. The next participant and the last participant is Kajal Verma and Sunita Esampalli. Kajal
Yes,
Verma,
ma'am.
please start.
Yes, ma'am. Ma'am, am I audible?
You're audible.
Yeah, Kajal, you can start your presentation. We are waiting.
Yes, so once again, just once again, I'm sharing my PPT.
Okay, it's not coming, no problem. You can just tell it orally.
Okay, sir. Sorry for the inconvenience, sir. Good evening, everyone. Myself, Kajal Verma from St. Anne's College, and my topic for today's presentation is Health and Recreational Facilities in India. So basically, I would like to give an introduction on health economics. It's a disciple of economics which deals with three basic questions. Like, do we have finite resources to draw upon in the case we get sick? And are we incapable of predicting the future with perfect accuracy? And do we live in a country which levies taxes on its citizens? These questions signify the importance of health economics. And coming to health facilities in India, the healthcare system in India is divided into three basic levels. The primary level includes sub-centers and primary health centers. Secondary level includes smaller sub-district hospitals and community health centers. The tertiary level includes medical colleges and district general hospitals. The rural health statistics provides a critical source of information on public health infrastructure, and it also aids in policy intervention and decision-making policies of government. I have collected few statistical data from Ministry of Health and Family Welfare. The first referral unit, it's an existing facility and it can be declared as fully operational FRU on certain conditions. Healthcare is so much related with economy because countries with poor health condition find it harder to achieve sustained growth, and good healthcare system ensures a strong economy. Few challenges faced in the development of a healthcare system are healthcare without a holistic approach, fake doctors, partial success of the policies and health programs launched by government, poor insurance penetration.
Please conclude it.
Yes, ma'am. I have collected the data from Ministry of Health and Family Welfare and few articles from newspapers and magazines. And my motive to write this research paper is to create awareness about the healthcare system of India and glorify its significance. And the COVID-19 situation has created a need to develop the healthcare facilities of India. Thank you.
Thank you, Kajal. The event is facing a conclusion now. Join me in giving a round of applause to all the presenters who are gathered here. Now, the rapporteurs of all three technical sections will present their report. Technical section 1. Technical section 1 will be presented by Ranjit Kumar, sir. Online participants, please fill up the form in your chat box.
Good evening, all of you. First, I thank our beloved HOD ma'am for having given this wonderful opportunity to the report here in the technical session 1. Next, I thank the chairpersons of this technical session. Congratulations to all the paper presenter for this technical session through the online mode. Totally, 27 participants have sent the papers, but only 17 paper present in this session. 12 paper from mental health, health care, health expenditure, and health insurance. 12 paper from impact of health in economy. 3 paper from status of women health. In conclusion, we see that health an important factor of our country. Most of the paper were on health expenditure, challenges, and problem of health system. Health sector, health indicator, mental health, and issues and health programs. Some papers are analytical and some papers are theoretical. Once again, congratulations to all the paper presenter. Thank you. Thank you.
The next report will be present.
We'd like to announce the best papers for the participants who are presented through online. May I request my colleague to announce the results.
We're very happy to announce that the first place goes to three people we have selected, 3 persons, 3 places. First place goes to Prasanna Jeet S. Babe and Neha K. Satlorina. Relationship between IMR, economic growth, and health expenditure in India. Second place goes to Mary Leah CA, impact of pandemic on ASHA workers in Kerala, with special focus on Cochin Corporation. And the third place goes to T. Sangeeta and Deepthi Ranga. Reclamation in health sector is the pania of the care economy. Thank you, participants. It was very nice experience for us listening to you all. Thank you so much for the opportunity given by the economics department, the head and the faculty. Thank you so much.
Thank you so much, ma'am. Thank you very much.
Congratulations, winners. The next report of technical section 3, technical section 2 will be presented by Dr. Napoleon.
Deepthi will be crying now.
Good evening, all of you. The technical session 3 was chaired by Dr. Arun sir, Assistant Professor in Economics, Government Arts College for Men, Nandanam, Chennai. In the technical session 3, 14 research papers were presented, out of which 60% of the paper were on the importance of having healthy insurance scheme. Couple of papers were on problems faced by women in receiving healthcare services. And one paper was on occupational health status of tribes in Andaman Nicobar Island during the pandemic period. Overall, it was felt that government health expenditure has to be increased and to reduce out-of-pocket expenditure. Then, thank you. And once again, I congratulate to all the paper presenters. Thank you all.
The last report will be given by Dr. S.R. Netaji, sir, for the technical section 3.
Okay, good evening to all. In technical session 3, this was chaired by Dr. Fenale and Shanti Merlin. In this technical session, research papers was presented on various topics related to health economics. Nearly 21 presenters have presented their paper, out of which 10 papers were on medical tourism, 6 papers on women in health, and finally 5 papers on medical tourism. Thank you.
Good evening, everyone. This has been a day of knowledge, and we have more pearls of wisdom to drop in your pails. Firstly, I call upon our HOD, Sita Lakshmi ma'am, to honor our guest, Dr. J.V. Arun, with a memento as a token of respect.
Dr. Arun, while being no stranger to our college, has a great deal of accomplishment behind him. I request Dr. S. Sita Lakshmi, HOD of department, to take up the stage and share those accomplishments with us.
I'm very happy and proud to introduce Dr. J.V. Arun because he is our alumnus of our department. Give a very big applause to him. Dr. J.V. Arun, Assistant Professor of Economics at Government Arts College for Men, Nandanam, Chennai. He has about 15 years. He has 15 years of experience, teaching experience. His research interests primarily lie in health economics with a focus on issues in utilization of healthcare services and household health expenditure. He has published a good number of research articles and presented papers at various international seminars and conferences. Apart from that, he served as a research person in various colleges. And also he has conducted seminars, workshops, and a number of webinars. He has also delivered invited lectures in various academic forums. In the year 2019, he was honored with the Best Social Scientist Award by Indian Academic Researchers Association. Article written by Dr. J.V. Arun have appeared in leading Tamil newspaper Dinathanthi and in Pudhiya Thalaimurai magazine. Recently, he has brought out a book titled COVID-19 in Tamil Nadu, Repercussions and the Avenues Ahead. As a keen researcher, he has completed a project work on urban sanitation, which was sanctioned by Tamil Nadu State Council for Higher Education. He also been sanctioned a major project on climate change by Indian Council of Social Science in 2021-22. So have a good day to all of you. I hope you will follow the footsteps of Dr. Arun.
A good event never ends in the world. They take only a pass and keep us awaiting for the next. I request Dr. Arun to hit the pass with the last speech of the day on reframing the Sustainable Development Goals targets for good health and well-being.
Good evening, one and all. Being an alumnus of Bishop Weber College, I feel elated to deliver the valedictory address of the International Conference on Prospects and Challenges of Health Sector in India. Before starting up, I would like to thank Reverend Dr. D. Chandrasekharan, Bishop of CSI, Tiruchirappalli, Thanjavur Diocese, Chairman and Secretary, College Governing Board, Dr. Paul Dayabaran, Principal, Bishop Weber College, and Dr. Sita Lakshmi Madam, convener of this international conference, Esther Madam, and other faculty members of the department for inviting me to this academic event. My topic is on reframing the Sustainable Development Goals, SDG 3, targets for good health and well-being. To set the pace for this session, I would like to brief you about Millennium Development Goals, which is the precursor for the Sustainable Development Goals. Go to the, Millennium Development Goals was slotted for the period 2000 to 2015 by the UN Development Council. And there were like some 8 MDGs, like 8 MDG targets were there, out of which like 3 were allotted to health, say reducing the child mortality rate, improving the maternal health, and combating the HIV, AIDS, malaria, and other diseases. Because at the point of time, like HIV was at its peak, that is like during 2000-2005, like it was at its peak, and like in the world across, like all over, like people try to bring down its rate. In fact, like when you talk about MDGs, like it was so successful in achieving all of its target, particularly in reducing the child mortality and maternal mortality rate, like it was able to reduce above like 50%, 50%. But then like eventually it fell short of the target. But again, it gave confidence to all the developmental economies across the world to one way or other way to control all these health issues across the globe. But major disadvantage or a major defect of Millennium Development Goal was that like there was like huge regional imbalances, particularly in the case of Sahara region and low income countries. Like we were not able to reduce the child mortality rate, or we are not able to increase the maternal mortality rate. After the closure of Millennium Development Goals, we started with Sustainable Development Goals. Obviously, you must be knowing the period for Sustainable Development Goals. It is for a period of 15 years. That is from 2015 to 2030. Okay. So again, like this you will be very much knowing about it. Like there are like 17 goals under Sustainable Development Goals, under which like the third one is meant for health. That is like good health and well-being. That is the thing. And like put together all the goals, like there are some 169 targets for SDG, including this poverty reduction, like clean water and sanitation. You take all those things and put together, there were 169 targets are there. And for health alone, like we had like some 9 targets. So in this session, we are going to discuss in deep about those 9 targets, where we are as a country, and what kind of policy interventions we have put across, and how effective these policy interventions, and what kind of adjustment that has to be made in the future. In that way, like this whole session has been planned. Okay, and like some 2 years back, Sustainable Development report was submitted, and like India was at a pathetic situation. Like it was ranked somewhere around like somewhere like near like 117 out of 166 countries. Almost like we are at the bottom of the table when it comes to this Sustainable Development rate. In fact, like among the Southeast Asian nations, except Pakistan, like we were below all other countries. We were below Bangladesh. Even we were below Sri Lanka. But again, like when the next report comes, things might change, because like you all know like how bad Sri Lankan economy is going through. But again, as far as like 2020 is concerned, like we were performing worse than Sri Lanka, we were performing worse than Bangladesh, we are performing worse than other neighboring nations. So such is the case, and like, but we have like bigger aims, and let's see like how far we can achieve those goals, particularly in case of health. So as I was telling you, like there were like 9 important targets under Sustainable Development Goals. Health. The first one is to reduce maternal mortality rate, and the next one is to end all preventable deaths under 5 years of age, and the third one is like to eliminate communicable diseases. We have communicable diseases, non-communicable diseases. Both communicable diseases and non-communicable diseases are fixed as a target to be reduced. And like tobacco, we on this particular SDG 3 health, like aimed at reducing road accidents, like it aimed at reducing alcohol consumption, like it aimed to give more rights to women in terms of reproductive health care services. Likewise, like 9 targets were fixed under this SDG 3. And apart from this, like 4 means of achieving the targets were also prescribed by the SDG itself. Okay, how to achieve those 9 targets, like for which like 4 means of achieving those targets were also been prescribed by the same UN Development Agency. Okay, next one. Okay, this is a comparison between MDG and SDG. Like when you compare this MDG and SDG, like I said, like there under MDG we are able to make progress, but not like we are not able to achieve any of those targets. So 3 targets from MDG were included in SDG. That is like reducing maternal mortality, like preventing newborn and child deaths, and reducing the epidemics like AIDS, TB, malaria, and non-tropical diseases or something. And other remaining 6 targets were newly introduced into SDG 3. Okay, next slide. Okay, the first target, like it goes like this. Like by 2030, we need to reduce the global maternal mortality ratio to less than 70 per 1 lakh live births. Okay, first we need to know what is this maternal mortality ratio. I'll give you a quick definition. Like it is a number of maternal deaths during a given period of time per 1 lakh live births. It's as simple as that. So when you compare with developing nations is 14 times higher than the developed regions. Okay, And 95% of maternal deaths occur in low and lower middle income countries. And for those who doesn't know, like where we are under as far as countries are concerned, we fall under which category? Lower middle income country. Okay, so we fall under lower middle income country. And because of this MDG, we were able to reduce our maternal mortality rate about like 50% we were able to reduce. Okay, that was till 2015. And in 2017, government of India introduced the national health policy, like national health policy, but like it is nothing to do with the SDG actually. Like India has its own agenda, and it tried to reduce the MMR by 100 per 1 lakh lives by 2020. But please do remember, SDG suggests that like MMR has to be reduced 70 per 1 lakh lives. But our policy suggests like it has to be brought down to 100 per 1 lakh lives. And what we are able to achieve as far as MMR is concerned, that like we are able to bring it down to 103 in 2017-19. That means the target that we fixed under national health policy, we might able to reach it. Like it is only 100 per 1 lakh lives, isn't it? But SDG 3 says that like it has to be 70 per 1 lakh live births, but like in 2030, we do have time. We have like some 8 years time within which like we have to bring it from 100 to 70 live births. For which do we have any policies? Okay, so that is what we are going to look in the next slide. We have number of policies. My intention is not to brief you about like when the policy was launched, like what are its objective and on all these policies, like you're seeing in the screen is to reduce MMR rate, right from the Janani Suraksha Yojana. That was the first one, like which was launched in 2005. And also like Janani Sishu Suraksha Karyakram, all these programs like aim to bring down the maternal mortality rate. Not only these things, like there is another one important strategy which I have left out. There is one thing called RMNCHAN strategy, reproductive, maternal, newborn, children, adolescent child nutrition strategy is there. And that is the latest one. Like it is not there actually. Now only I'm able to recognize, like I have not included that thing in there, like but like RMNCHAN strategy is there, and like it has its own ways of reducing, bringing down the MMR. One way is to increase the institutional delivery rate. After that strategy came into the picture, like we were able to increase the institutional delivery. And one reason why we have like so much of MMR like in India is that like normally like deliveries will happen in our home itself. Like I'm talking about rural areas. I'm not talking about urban places. So you go to rural places, like all deliveries happen like, just like that. So because of which like so many deaths are happening. And that is one thing. And apart from this thing, like excessive bleeding after delivery is also considered to be one of the major reasons for MMR. Okay, scientifically it is proven, and like for which like the intervention measures has to be given. But again, these kind of measures were not available in the primary health centers of India. Do you understand? We have like primary health centers, we have secondary health centers, we have tertiary health centers, all things there. But then again, like these people from rural people, they were not able to take the women folk to the urban places for delivery. They will think like, okay, primary health center is there, like we will take our women, we will take our wife, or we will take our sisters to the primary health center. But the primary health centers, we don't have the facility to stop this kind of things like excessive bleeding, all those things related to that. And that is also one of the reasons why we have like higher maternal mortality rate. And we need to speak about all these things. I mean, unless otherwise you come to know all these things, like we can't take preventive measures to bring down this big health issue. Go to the next slide. And then second target is by 2030, like we want to end preventable deaths of newborns and children under 5 years age. Again, like this aims for 12 per 1,000 live births and under 5 mortality to be at least as low as 25 per 1,000 live births. Okay, and what is this NFHS 5? That is a latest report that we have. This IMR current status is like 32, but NHP, the National Health Policy target is 28 by 2019. That means that India might achieve this particular SDG target. Do you understand? If see, NHP says that like you have to bring it down 28 by 2019. Like by this time, like you would have achieved infant mortality rate. When it comes to neonatal mortality rate, the current status of India is 23, and the NHP aims for 16 by 2025. Whereas like SDG says that like it has to be 12 per 1,000 lives. So if you closely follow this statistical data over here, like it tries to say that like we are well on course to achieve all those courses, provided the policies are implemented in a successful manner. Like here, like the implementation, implementation is a big issue as far as India is concerned, because the policies, the programs, there are like n number of policies and programs we have, like, but again, like we are not able to see success when it comes to maternal and child health care. Okay, let's go to the next part. And again, as I said, like number of programs are there, and the third one is to end the epidemics of AIDS, tuberculosis, malaria, neglected tropical disease, and combating hepatitis B, waterborne diseases, and other communicable disease. And no, go to the earlier one. Yeah, if you look at the incidence of tuberculosis, that is TB, malaria, AIDS, all these things where we were able to bring it down. Like when you like say, take the case of 2000, the year 2000, TB was 28. Like in 2020, we were able to bring it to 188 per 1 lakh people. Likewise, like for malaria, we were able to address it. For hepatitis B, like we were able to address it. But like when you compare that with global average, like we are falling short. Do you understand? Like when you compare with the previous year, like India was able to bring down all this malaria, TB, AIDS, everything. But like when you compare with global figures, we are nowhere near. Like we are like standard. Like it means like we require like more strategical policies to control all these health menace. Go to the next slide. And even for these things, like government interventions are there, right from National AIDS Control Program is there. And then like the second one is the most important thing when it comes to eliminating these epidemics like TB. National TB Elimination Program, which aims to eliminate TB in India by 2025. It aims for 0 TB patients like in 2025. SDG itself says that like only in 2030, like countries are expected to eliminate TB, but India aims for elimination of TB in 2025 itself. And that is a like big plus, or like that is a big positive as far as this particular target is concerned. Okay. So likewise for other vector-borne diseases and other diseases, like India has its own policies and programs. Okay, next slide. And the fourth target is by 2030, reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and promote mental health and well-being. Okay, so when it comes to India, major non-communicable diseases are, we suffer from cardiovascular diseases, chronic respiratory problems is higher in India, cancer, diabetes, like even like youngsters, like nowadays, like they are suffering from diabetics, and all people are diabetic than before. So NCD is higher, like in fact, like almost like 60% of death happens because of NCD. That is what statistics says. It's not because of any other communicable diseases. We die mostly because of NCD. And again, like, no, go to the previous slide. Okay. And when it comes to mental health, particularly like mental health, the economic loss of due to mental health conditions, like it is estimated to be somewhere around 1.03 trillion US dollars. So, I mean, somebody like when they were presenting papers, they were talking about stress, depression, all these things and all. Before it was a taboo to speak about mental illness and all. And nowadays, like, I mean, some kind of awareness level is there and people are approaching this psychiatrists, psychoanalysts, all these things. But like, because of this mental illness, loss of working days, you understand? So it is higher in India, and that has to be addressed at an appropriate time, because of which like productivity level is coming down. That is a whole point put across over here. Next slide, please. And again, for mental health care, like in 2017, we are like a Mental Health Care Act was there. Mental health care programs were there, and health and wellness centers were there. De-addiction centers and rehabilitation services was there. And even like in 2021, like, I mean, latest edition was not there. Like there was like another Allied Healthcare Services Act was introduced by the government, which talks about psychiatrists, psychoanalysts, all this professional. It has to be brought under behavioral sciences. So, and such kind of initiatives were taken by the government very recently when it comes to mental health issues. Okay, go to the next one. The third target is about to strengthen the prevention and treatment of substance abuse, including narcotic drug abuse and harmful use of alcohol. And you may think that like only drugs has been smuggled across borders and neighboring territories and all. It is not so. Out of the total alcohol consumed, like almost like 26% is unaccounted alcohol, spurious liquors. That means like 26% of the liquor considered spurious, illegal one. Okay, so that means like how harmful it is. Like you yourself can make a judgment out of it. When it comes to India, like 16 crore people between the age group of 10 to 70 years are alcohol users, and out of them are somewhere around 6% are addicts. Like, I mean, they can't like go to bed like without consuming alcohol. That kind of population is 6% of 16 crores. Like, okay. And when it comes to drugs like cannabis and also other problems, like some 3 crore individuals like suffer in India, and these are all like staggering numbers, and this has to be taken very seriously. And as far as like injection drugs is concerned, like somewhere around like 9 lakh people are affected in India alone. I'm talking about India. I'm not like talking about other world nations or other nations. No, in India alone, this much of amount of number of people have been affected due to alcohol use, substance abuse, drug abuse, and all those things. What kind of strategies we have? Let's see. Okay, go to the next slide. And the first thing started way back in 1985, Narcotic Drugs and Psychotropic Substances Act. And then we had like NDPC policy 2011. And then the most important thing was that the third one, the National Plan for Drug Demand Reduction for 2018 to 2023. And it not only tries to reduce the demand by strict measures, it tries to rehabilitate people who suffer, who are addicted to drug abuse. And the agency was given powers to execute this drug demand reduction plan. The agency name was National Institute of Social Defense, an autonomous body like which comes under like Ministry of Social Justice and Empowerment, which has been given by the responsibility to implement the activities of National Action Plan for Drug Demand Reduction. Okay, let's go to the next target. So the next target is to halve the number of global deaths and injuries from road traffic accidents. You may wonder like why, I mean, road accident, why it has to be put across in SDG 3 and all. And it is serious than COVID pandemic in India. The number of people who die in road accidents is higher than who died due to pandemic in India. You imagine the numbers and all. Last ever, like I mean, you browse, you Google, whatever number you get, which is less than the numbers, which is less than the people who die due to road accident. So India is like in a very bad situation. And again, like I can give you number of data. I mean, some of them will be interesting. India accounts for 11% of global death in road accidents. That is the highest in the world. Okay, so be careful when you drive, like whatever safety measures they say, like please follow it. If they say wear helmet, and of course, like it's going to spoil your hairstyle, everything. But again, like it is for safety purpose, and like do wear helmets. If you drive, I mean, car, like wear seat belts. I don't think like it will spoil your shirt or like whatever it is, accessories, all these things. Like have proper precautionary measures when you drive. Like it is the most serious thing in Indian roads. And of course, like the government has its own initiatives. Like government of India like came this particular program, National Road Safety Week, which was like conducted January 11th to 17th of 2022. The theme of the campaign was Sadak Suraksha Jeevan Raksha, which means like road safety and children. Okay, so it is just there. And okay, we can go to the next slide. Okay, the next 7th target was by 2030, like we want to ensure universal access to sexual and reproductive healthcare services. I'm not talking about maternal health here, like I'm talking about girls, adolescent girls and women having their right to express about sexual and reproductive healthcare services, when to have a child. It is not the decision given to any woman in this part of the country. I'm not talking about across the globe. In part of the country, you can make a decision. At the best, like your in-laws can make a decision, or at the best, like your husbands or like your would-bes can make a decision when to have a child. That means like you don't have a say in reproductive activity. I'm not saying this, like SDG says that. Not only in India, like even in sub-Saharan countries, like the same is the case. Okay, so you can't like, okay, so that is the thing. Like, let's go to the next one. And what India does with that. Okay, what kind of measures? Of course, like, I mean, you might be knowing about this primary health services, secondary health services, tertiary health services. And under the national health policy, the government made it possible. I'm not saying it made it mandatory, like the government like gave a try that all aspects of reproductive, maternal, child and adolescent health should be brought under primary health services. That it has to be brought to the doorsteps of rural areas. Okay, so that is one thing. And in the budget, union budget 2001 to 2021-22, like government of India, like established this particular commission, National Nursing and Midwifery Commission. You go to any primary health center in rural areas, like you mean maximum and like a midwifery, Asha will be there, isn't it? Okay, one nurse will be there, ANM will be there. Who will not? I mean, who or he or she will not be qualified enough to tackle all these kind of issues. So government of India like established a commission like to provide a good training for reproductive health services. Okay, hope this gives fruit like in the near future. And but again, having said all these things, like on the flip side, like during this budget, like government of India reduced allocation to contraceptives given to states. Normally, like central government gives contraceptives to the states. Okay. But again, like during this period, they have reduced it. But like one reason, like given for that, like due to COVID, like government like was forced to divert its health resources to COVID prevention and other activities. So that is one reason, like being said that. But again, like it has taken a back seat for some reason. Even if it is a valid reason, like it has taken a back seat. Let's go to the next thing. And most important thing, like when it comes to SDG 3, like it aims for health coverage for all, universal health coverage. And even like our own national health policy like makes a shift from moving beyond health to focus on wellness and prevention. Okay. And one more thing is that National Medical Commission Act 2019 also tries to improve access to quality and affordable medical education, because of which that like we can give it aims to give like better medical services to the affected a lot. And out of all these things, like the last one is the most significant part, Ayushman Bharat. Many of you might have heard about this Ayushman Bharat scheme. There are two important components under this scheme. Like it aims to establish 150,000 health and wellness centers to deliver comprehensive primary health care center. That is 150,000 health and wellness centers across India. Why it has been brought into the picture means so that like all individuals, like whether you are like a rural, whether you are urban, whether you are women, you are men, whether you are socially backward, economically backward, whatever you be the situation, whatever be the strata you are living in, you should have some kind of medical facilities to attend, okay, to depend on. So for keeping that in mind, like the Ayushman Bharat scheme was launched. And another one more thing is that like health insurance coverage, like it goes by like this Pradhan Mantri Jan Arogya Yojana scheme. And under this particular health insurance coverage, rupees 5 lakhs per year to over 10 crore poor and vulnerable families for seeking secondary and tertiary care will be given. The first one was as far as primary health center is concerned. The second one is for secondary and tertiary health center is there. Like normally, like when you go to this secondary and tertiary care, like you have to spend out of your pocket. So that is the thing. To bring it down your out of pocket expenditure, government like has introduced this insurance scheme, like under which like 5 lakhs will be given to over like 10 crore poor people. So that is one scheme. But I mean, these are all at a scheme level. I'm not saying like things will turn overnight or by 2030, like we will be able to achieve universal coverage and all. It is there in paper, like I'm sharing it with you. Okay, next one. The 9th one is like by 2030, substantially reduce the number of deaths and illness from hazardous chemicals like the air pollution, the air, water pollution and soil pollution. All contamination has to be reduced. And when you compare with India with a regional level, that is like even with Southeast Asian regions, like we are like well below the average level. And again, like you are nowhere near to global average. When it comes to the government intervention, we have this age-old Air Pollution Control Act, Water Pollution Control Act and all, like 1984, all these things. But again, in recent past, like we have not made any amendments to those act. Normally, in between, like amendments were there. But again, in recently, like when it comes to air, water pollution, like we have not made any strategic amendments to control all those things. Only thing that we made was to control coastal regulation zone and all, like because of climate change, like seawater level is going up, for which like we have bought like some regulation thing. And I mean, deforestation is going on. To control that, like we have like brought some acts, but not to control air, water pollution. Okay, and that is the thing. And the next one, I said that there are like 9 targets, and for this 9 target, like 4 strategies has been listed in that SDG 3. And tobacco consumption, again, like tobacco consumption is high when it comes to India. And normally, like why tobacco is sold across is that it brings some kind of revenue. People know that like it is not good for health. But again, like it brings like a lot of excise taxes. But again, like for every 100 received as excise taxes, the government is forced to spend like more than 800 rupees. So there is no point in encouraging the sales of tobacco. And that is the thing. And again, like economic cost of tobacco is almost like 1% of our GDP. Imagine like our GDP and like 1% like is going waste because of the consumption of tobacco. And one step like the government of India took to control the reduction of tobacco consumption is that in 2019, like it banned e-cigarettes and all. To reduce the consumption of cigarettes, like the private players introduce e-cigarettes. Do you understand? But again, it is not a, it cannot like take you away from addiction to tobacco. So realizing that, like, again, government of India like banned e-cigarettes as well. So that is one thing. And the next slide. Support to R&D. Okay, the main thing is that like we aim to reduce communicable and non-communicable diseases, which we have disease, and how to approach, how to do about this, how to go about this. And like one thing is like R&D. Okay, so R&D is there, but again, like in our budget, like in 2021-22, like we reduced allocation to health research by 35%. So SDG says that all this non-communicable disease, communicable diseases has to be brought down. How to brought down means like you have to do R&D. Okay, if you want to do R&D, like you should allocate like more funds to R&D. But again, what the government did like with this union budget is like it brought down the allocation to health research by almost like 36%. Okay, so that is not a strategic reply to bring down communicable and non-communicable diseases. Next one. Increase health financing and recruitment, development, training, and retention of health workforce. When you compare our numbers with China or any other developing nation, like even in terms of dentists, in terms of availability of nursery and midwifery, in terms of pharmacies, we perform very bad. Okay, so our numbers are less than these countries. And what we have to do is that we have to improve the trained professions. Do you understand? That only like will give you the desired result. And for which like this 2021 bill was introduced. That is, it goes like this: National Commission for Allied Healthcare Professions Bill 2021, which aims to regulate and maintain educational and service standards for healthcare professionals. Okay, so that is one thing. That is a response by the Indian government to increase our health workforce. Go to the next slide. And risk reduction and management of national and global health risks. And whether you admit or not, like no country was prepared for COVID-19. Nobody, even now, like nobody knows how to respond to this pandemic. So all countries are aiming not to train themselves how to combat this pandemic, COVID. They are trying to be ready for the next pandemic. There is a huge difference between the thought process nowadays. They are not trying to combat the present one. It has gone out of hand. Do you understand? So we are going to respond to it. But what people are aiming across the globe is that like if some next pandemic comes up, like how we are going to combat it. Okay, how well prepared we are going to be. So that is the thing, like in other developed nations have started allocating funds for this. And what happens with India is that like for the next 6 years, it has allotted some 64,000 crores to detect and cure new and emerging diseases. Okay, so that is a policy response taken by our government. Okay, next. And the greatest battle. So this UN was proposing this SDG, but again, like nature has its own response, COVID-19, and across the globe, like we were able to see that it has stalled. In fact, like it has reversed the progress made so far. Do you understand? We were not able to care more about child health. We were not able to care more about maternal health, because all we were concentrating about what? How to respond to COVID. Okay, because of which whatever progress we made, like now we are going back. Do you understand? Such is the case. Go to the next one. And we made like very good progress in terms of TB, in terms of child health, in terms of maternal health, HIV, even immunization and all. I mean, now like it is like decelerating, like it is going backwards. And in fact, like malaria is going up. And we were able to reduce malaria and all because of this COVID. Like, I mean, statistics says that malaria numbers are going up across the globe, particularly in sub-Sahara region, African countries. And the next one. Okay, COVID versus India's SDG plans. Definitely, it has disrupted our progress in controlling HIV. And when it comes to TB also, like there was a huge drop in diagnosation rate. So some 35% to 40% drop in the TB diagnosation rate is found with India, Indonesia, Philippines, and South African countries. So that means like our progress has been reversed because of COVID. And only exception is that like mental health has gained prominence because of COVID. People started talking about stress, depression, how to tackle it, where to get counseling. All these things like gain prominence, gain currency because of COVID. That is the only positive like happened because of COVID when it comes to SDG targets, accomplishing the SDG targets. Okay, go to the next one. And what kind of challenges do we have? Whether we can move forward and achieve all these targets, or otherwise whether this SDG has to be reframed, or otherwise we have to go for some other, like MDG we had, like again we had SDG. After 2030, whether we should have like some other DG. Do you understand? Or otherwise are we going to postpone our targets like every 15 years? That kind of thinking started to creep in health experts' mind. And health funding is a big issue, not only in India, world across, like health funding is a big issue because we are going back. Economic progress is not there. And that is the thing. And private parties are taking multiple forms in India. So whatever suggestions we put across so far, like in terms of public health response, they understand. But again, like when it comes to India, who dominates over here is private people. Do you understand? Like, so it is lopsided as well. It is not like, I mean, evenly balanced. Like it is lopsided, particularly when it comes to this secondary and tertiary sector. It is dominated by the private properties, but private people. So that is again like a very big thing, and that has to be addressed when it comes to India. And the intersectional nature of inequality and all. I said that like women should have a greater say in reproductive health services and all. But again, religion comes in between. It cannot be, I mean, it cannot be practiced by all religious people. So like inequality is there. And when you say like universal health coverage, like it concentrates only about economic inequality. But in India, we have like different kinds of inequality. We have like social inequality. We have like gender inequality. We have like so many inequalities. But like this thing, like particularly like talks only about economic inequality, which is not going to work in a country like India. See, it has to be addressed at a multidimensional level. Multidimensional approach should be there to address these issues, which is lacking when it comes to SDG targets. And this SDG does not have a systematic tracking system when it comes to primary health centers. It only says that like MMR has to be better, like IMR has to be brought down, all these things, but it doesn't have any tracking record when it comes to primary health centers. No, previous one. Yeah, how, like rather than talking about medicines for COVID and all, how to prevent the any pandemic to happen, like that is the thought process over here. And then like financial risk protection, like we do, I mean, it doesn't talk about health insurance. It says that health financing should be there, but like nowhere like in its draft, like it mentions about health insurance. Okay, so in that way, like there is a demerit like in the drafting side of SDG 3, potential policy implications, and integrated PhD based approach should be there to achieve SDG targets. and a holistic approach should be there. Like here we have to identify highest burden disease rather than we should stick on to what SDG says or what UN says to us. Some other disease might be a prominent issue over here that has to be concentrated rather than dwelling deeper into United Nations agenda. And the health system should be designed in such a way the insurance schemes and essential medical packages has to be reached to all. That has to be done to achieve those 9 SDG targets, which is definitely lagging in SDG strategical measures. Okay, next slide. And final part. No. Okay, thank you. I don't know why you clap in between. You want me to stop or like you think like it's good? Okay, either way, like I'm going to finish like with this particular thing. See, it's not only about government when you want to achieve higher health agenda and all. It's all about us. We stakeholders all has to come together, whether the users, whether the supplier, whether the NGO, all should come together. Only then like we can at least go near to SDG targets. Okay, that's all from here. Thank you so much for your patience hearing. And if you find fault with me, nothing to do with me, because I'm a product of Bishop Weber College. Blame it on Bishop Weber College. Thank you guys.
Thank you, sir, for their wise words. Let us applaud the efforts of all the contestants who have worked hard in order to shine in their performance. But only the shiniest diamond attracts the admirers. It is now time to announce the Best Paper Award. I request Dr. Arun to present the winners with the award.
Best paper for technical session 2, Uma Maheshwari, first place, third B Economics, Bishop Heber College, Trichy. The second place goes to Sneha Kumari, MPhil, Research Scholar, Annamalai University. And the third place goes to Subiksha L, second BA Economics, Bishop Heber College, Trichy. Best paper for technical session 3, Rashika and Vidya are first BA Economics, Bishop Heber College, Trichy. And the second place goes to Yuvaraj N, third B Economics, Bishop Heber College, Trichy.
Congratulations, winners. I request Dr. Arun and Dr. Sita Lakshmi to certify the participants from other colleges.
Periyar Government Arts College, Kadalur. I request the participants from other college kindly get your certificates. Periyar Government Arts College, Kadalur, Annamalai University, Chidambaram. Please, one of you come and get the certificate. Madurai Kamaraj University, Madurai. Holy Cross College, Trichy. Thirukalanjiyappar Government Arts College. Urumbu Dhanalakshmi College, Trichy. Government Arts College, C. Mathur. Indira Ganesan College of Arts and Science. Aringar Anna Government Arts College, Musiri. Urumbu Dhanalakshmi College, Trichy. Government Arts College, C. Mathur. Aringar Anna Government Arts College, Musiri. I request the representative from Urumbu Dhanalakshmi College, Trichy, to come and get the certificate of participation.
We are now at the end of this conference. To give a perfect end this event, I now request Dr. E. Thelma, Assistant Professor of Department of Economics, to deliver the vote of thanks.
Good evening, everyone. Thank you is such a prayer that cannot be seen or touched. It must be felt by heart. I feel honored and privileged to propose the vote of thanks on this special occasion on behalf of the Department of Economics. First of all, I would like to thank our creator for the successful conduct of this international conference on prospects and challenges of health sector in India. I would like to place on record our sincere thanks to our Bishop, Right Reverend Dr. D. Chandrasekharan, Chairman and Secretary of the College, and Principal Dr. D. Paul Dayabaran for having provided the opportunity to conduct the international conference. On behalf of the Department of Economics, I thank Dr. S. Sangeeta for delivering the inaugural address. She enlightened the audience with her erudite account of the topic, Dimensions of Human Resource Development in India. I express my gratitude to Dr. Doris Padmini S. Salvarathinam for her virtual presence in spite of her busy schedule. She enriched the knowledge of the participants on the topic Socio-economics of Healthcare Among the Poor. I am thankful to Dr. Shad Azad Khan for his virtual presence in the international conference. He filled the vacuum in the minds of the participants by lecturing on the topic Skills for Future Healthcare Workers. I must mention our deep sense of appreciation to Dr. J.V. Arun, our alumnus, for his valedictory address on reframing the Sustainable Development Goals, targets for good health and well-being. I acknowledge unwavering support and guidance received from our HOD, Dr. S. Sita Lakshmi. We are overwhelmed by the response from the professors and scholars of economics all over India and abroad to participate in this conference. We thank you all. I am extremely thankful to the members of the Faculty of Economics, Bishop Kiba College, Dr. S. Shantigetsi, Dr. H. Esther Rani, Dr. D. Ranjit Kumar, Dr. D. Napoleon, Mrs. M. Mani Meglai, and Mr. S. R. Netaji for their ardent support in organizing and conducting this conference. A special word of thanks to Dr. B. Napoleon, Assistant Professor in Economics, who has edited the conference proceedings and took efforts to get the ISBN number. Our special thanks to the technical staff members of IT Department of Bishop Kiba College for their able assistance in conducting this conference virtually. Without their technical assistance, this would not have been a success. I am very much thankful to Kirtana of 3rd BA, Yalini and Karishma of 2nd BA, the MC team for their systematic comparing. I thank the student volunteers for their services. I thank all the students of our department for their enthusiastic participation. I thank Mr. Perianan for his extended help. Once again, I thank everyone for making this international conference a great success. Once again, I thank you all. Thank you.
There is no better way to show our unity and our patriotism than standing together and voicing the song of our nation. I request everyone to rise to their feet for the national anthem.
जनगण अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Good evening, students. Tea is served at the back of the auditorium. Please have tea and then you can leave.
Thank you, everyone.